I'll do it myself. I'll say if somebody falls on the floor, it can be two things. They lost their balance and they fell, or it can be like a blood pressure issue. Like all of a sudden they're walking, their blood pressure dropped, and they're down. The worst thing in the world you can do is immediately get a patient back up, because if it's a blood pressure issue, they'll go down again. So I usually tell them, however they fall, roll them over to their butt and make sure that they're okay. Make sure they didn't roll an ankle, their hips are okay, And don't ever try to stand anybody from the middle of the floor up. Even if they're contact guard, it's too hard on you and the patient. Have them scoot over to a wheelchair, or bring their wheelchair to them, or scoot over to the bed on their butt. And then instead of them having to stand from here, depending on which side is their stronger side, you can have them work on trying to get up on one leg, one knee, and then the family just helps get them to the chair. I always go over the fall risk and what to do if somebody falls and that kind of thing. But if somebody's supervision and they're leaving at supervision, that means they have to have somebody there 24 hours. They have to have somebody to supervise them. If they're modified independent, then they might be at home alone for a while. And so talk to the patient about that. If you're home by yourself, can you carry yourself home? Can you put your family on speed dial? Make sure anything that you're going to get at home, you're not having to reach up really high for or reach down low, that kind of stuff. No throw rugs. Talk to them about all that kind of stuff. We have a little handout we give to the patient. We make the families come in, especially the day before they leave, and we try to get them to spend one entire day with the patient. The whole night, nursing doesn't want to do, make them do everything so they know what to expect when they get home.
No, that's inpatient rehab. You don't always have that.
And acute care, they may not know. All of a sudden, tomorrow, you get there and they're like, hey, John Doe's going home tomorrow. And you're like, crap. So you got to run real quick and start training. But that's why in acute care, I'm always thinking that could be the last time I see the patient. So I'm always trying to, family, this is what you need to do. Where are you going? Are you going to the skilled nursing? Are you going home? Are you going to Whitaker? Figure out where they're going in, and that's where you start your training. But and then talk about, you always need to give the patients exercises to do at home. Give them HEP, and then review that with the patient and the family. Make sure that they're okay. And if they're really low level, it might just be supine Therex, and they're helping you. But if they're high level, it might be some standing exercises at the kitchen sink. Just make sure they're there with that kind of thing, and make sure that they're okay with it. The family can say it back to you. They know that they need to be there all the time. Driving is something I always like with patients. I always say, talk to your doctor, because we can't tell them they can drive or we can't. That's up to the doctor. But if they've had a neuro event, they need to be cleared by the doctor before they get behind the wheel. Car transfers, always do a car transfer. Even if somebody's modified independent, we go down and practice. Because most people are going to try to step into the car. You want to teach them to put their butt in first and then get the legs in. Talk to the family, especially in acute care. If you go home, what kind of car do you have? It's a 5-foot tall patient. I've got an excursion. Can you borrow a Camry? When you go home, have your daughter bring her whatever, that kind of thing. So they're prepared as opposed to going down and doing a slide board transfer up into an excursion.